not showing any symptoms, just waiting for the right moment to strike. So we have a normal T4 time bomb concealed in his jacket. It just goes to show that an elevated TSH is the most important and most sensitive lab value to look out for. Turns out that it's usually not helpful to check a T3 level. As I mentioned, T4 is converted to its more potent form, T3. And even in the setting of clinical hypothyroidism, this conversion is still occurring out in the periphery. So T3 may be normal or only slightly decreased. Next, let's illustrate the lab findings in central hypothyroidism, which is due to pituitary or hypothalamic disease, termed secondary and tertiary hypothyroidism, respectively. Keeping in the theme with the rest of the unit, a torn hype poster symbolizes hypothalamic disease, while a bashed pituitary punching bag represents pituitary dysfunction. In both scenarios, T4 will be low, but this time, TSH from the pituitary will also be low, or at least inappropriately normal, considering how low that T4 is. So to convey low T4, we have another T4 time bomb falling to the floor. While low TSH is embodied by our next henchman crouching low while stimulating that bow tie. Again, that's low or inappropriately normal thyroid stimulating hormone. In cases of your typical run-of-the-mill hypothyroidism, it's treated with oral levothyroxine. Levothyroxine is a synthetic form of your body's natural T4. So we've represented it here with this T4 plastic explosive. All right, so why do patients become hypothyroid in the first place? Well, the most common cause of hypothyroidism in the world is iodine deficiency, especially in mountainous areas such as the Himalayas and the Andes, as well as regions of Africa. However, nutritional supplementation of foods with iodine has led to improvement in rates of endemic goiter. We'll talk about this and more causes of hypothyroidism in our next video. The rest of this sketch is dedicated to the most common cause of hypothyroidism in iodine-sufficient parts of the world: chronic autoimmune thyroiditis, also known as Hashimoto's thyroiditis, embodied by the head of this whole operation, Dr. Hashimoto. And because every villain needs a super villainous sounding nickname, he goes by Dr. No Thyroid, that is. Hashimoto's thyroiditis is an autoimmune process that leads to destruction and dysfunction of the thyroid gland, leading to irreversible hypothyroidism. So notice that we, again, have hypothyroidism symbolized by that undone necktie. Also, take a look at Dr. No Thyroid's antibody-shaped pincher hands. Because an accident that you know what? No time for that backstory. Moving on. Hashimoto's thyroiditis is much more common in women, usually presenting in patients 45 to 65 years of age. And because Hashimoto's is an autoimmune disease, patients or their family members are likely to have other autoimmune conditions such as celiac disease, type 1 diabetes, or primary adrenal insufficiency. Hence the array of antibody-shaped tools Dr. No Thyroid brought with him. You know, being a doctor and all. He even has his name embroidered on the side of his old-school doctor's bag. Notice that HLA-DR3 and DR5 are highlighted. These MHC class II genes are associated with the development of Hashimoto's thyroiditis. It's thought that thyroid cells expressing these MHC molecules are more likely to be recognized as foreign by killer T cells. Specific HLA haplotypes may also play a role in molecular mimicry. For instance, if a virus makes a protein that looks similar to an endogenous thyroid protein, the body mounts an immune response to both the virus and thyroid tissue. Oops. In any case, there are three major ways the thyroid gland is destroyed in the setting of chronic autoimmune thyroiditis. First, CD8 cytotoxic T cells cause direct damage to thyroid follicular cells, embodied by our recurring killer T cell crusader. Medieval night every Thursday, by the way. Be sure to check it out. Secondly, activated CD4 T helper cells produce cytokines which recruit macrophages that invade the thyroid. So on the table back there, we've got our helper T square with a few cytocoins left as a tip, as well as our recurring macro cage symbol. This is your classic type 4 hypersensitivity reaction. And thirdly, antibodies are formed against the thyroid gland. So it's time to bring in some antibody cover fire. This is a classic type 2 hypersensitivity reaction. Your body is tricked into producing B cells that secrete antibodies targeting thyroid cells. Pretty much every patient with Hashimoto's thyroiditis has high serum concentrations of antithyroglobulin and antithyroid peroxidase antibodies. Thyroglobal on the side of that disguised transport vehicle should remind you of antithyroglobulin antibodies. Thyroglobin is a large precursor molecule produced by thyroid follicular cells. And those TPO cases for transporting illegal shipments of iodine are here to represent antithyroid peroxidase, or anti-TPO antibodies. TPO is an enzyme produced by thyroid follicular cells that plays a role in the iodide oxidation and organification process. So, all in all, we've got killer T cells, helper T cells, and B cells all working together to destroy the thyroid gland, ultimately leading to decreased synthesis of thyroid hormone. It's the itis in thyroiditis. Some patients also have antibodies that latch onto the TSH receptor, blocking the stimulatory effects of TSH. This, in turn, decreases thyroid hormone production. Just think of this clip-on tie falling off, with that antibody-shaped clip in the back. It just can't seem to bind to its receptor. Know what I mean? Now, don't confuse these with the TSH receptor antibodies in Graves' disease that stimulate the thyroid. You'll hear more about those in the third movie of our thyroid series, A View to a Grave. See that big inflamed thyroid bow tie worn by Dr. Hashimoto's sidekick getting shot in the arm? In early phases of thyroid gland destruction, release of preformed stored thyroid hormone can actually lead to a transient phase of hyperthyroidism, though this is typically short-lived. Diagnosis of Hashimoto's thyroiditis can be confirmed by demonstrating the characteristic lab values of primary hypothyroidism. Gradual loss of thyroid function leads to elevated levels of TSH and low serum T4. And in most cases, patients test positive for thyroid peroxidase antibodies. Clinically, elevated TSH can actually cause gland hypertrophy and development of an enlarged painless goiter, depicted here by Dr. No Thyroid surgical mask pulled down over his neck. Watch out for compressive symptoms, such as hoarseness or stridor, if the goiter is severe. Again, this is a painless goiter. Painful goiters we'll meet in our next sketch. And we'll be sure to emphasize someone getting smacked in the neck to evoke pain. On histology, the thyroid of a patient with Hashimoto's should show a lymphocytic infiltrate and the formation of germinal centers. Check out the dress pattern. It depicts an aggregation of lymphocytes. All those little blue nuclei, see? And they're surrounding a multitude of well-developed germinal centers. That's right, germinal centers. B cells are developing right here in the thyroid. The thyroid follicles become atrophic and are often lined with Hürthle cells. Hence the guy in the back hurtling over that dead follicle as he makes his escape. Hürthle cells, also known as oxyphil cells, are large epithelial cells containing granular eosinophilic cytoplasm and abundant mitochondria. Just look for deeply pink rings surrounding little atrophied pale follicles. The gland is normally diffusely enlarged, and there can be interstitial fibrosis as well. And finally, chronic inflammation in Hashimoto's thyroiditis is the most important risk factor for the development of primary lymphoma of the thyroid. So we've brought in our recurring symbol for lymphoma, a chessboard overrun with B-cell archers. Primary lymphoma of the thyroid is pretty rare, making up less than 2% of all extranodal lymphomas. The vast majority of primary thyroid lymphomas are derived from B cells and are of the non-Hodgkin lymphoma type. Remember that on histology, we did see a lot of B cells and germinal centers in that inflamed thyroid. Makes sense then that one of them could mutate and get all neoplastic on us. Thyroid lymphoma is the only thyroid cancer not clearly associated with radiation exposure. And unlike the other thyroid carcinomas, surgery is typically not performed as treatment. Instead, chemoradiation is used. Be sure to check out the last sketch of the series, The Man with the Golden Nodule, for more details. So that wraps up our discussion of hypothyroidism and the most common cause of hypothyroidism in iodine-sufficient areas, Hashimoto's thyroiditis. At the beginning, we covered the clinical presentation of hypothyroidism. And besides the more straightforward, low basal metabolism kind of stuff, some interesting manifestations include hypercholesterolemia, myopathy, decreased heart rate, contractility, and cardiac output, hypertension of all things, atherosclerosis, and coronary artery disease. And don't confuse myxedema, which involves glycosaminoglycan deposition causing non-pitting edema, with myxedema coma, which is just kind of like a super severe hypothyroid state where hypothyroidism, hypoglycemia, hypoadrenalism, and hyponatremia take over. Hypo everything. In the back, you have Hashimoto's thyroiditis, the most common cause of hypothyroidism in iodine-sufficient regions. Dr. Hashimoto's got a couple of pincher hands because it involves an autoimmune attack of the thyroid. There's a lymphocytic infiltrate with lots of germinal centers. There can be a transient hyperthyroid period as the gland releases all its stored hormone, but then a progressive hypothyroid situation with high TSH and low T4. And lastly, remember that lots of TSH can, over time, cause goiter. All right, on to the next sketch. Espionage, sultry women, an overly long gambling scene. Hypothyroidism. Goiters, okay, this is something.